Hospice Palliative Care Alliance, one of the sponsors for today's event, along with our close partners, the American Eurasian Cancer Alliance and the All-Ukrainian Association for Hospice and Palliative Care. We are so sad that Ukraine is under such duress with the war and with the recent destruction of the Children's Hospital. It's just been a horrific time, and it's all the more reason why we need to increase education on palliative care for colleagues in Ukraine. This is our first case conference with you. We've done case conferences in other regions and other countries and parts of the world, and found it to be a good sort of starting point to begin to expand professional education in palliative care. I would like to just make a note that we have three particularly impressive clinical colleagues with us today. Tom Smith from Johns Hopkins University and his colleagues. Tom is the professor of palliative medicine and oncology at Johns Hopkins University. Marcin Twistik is also head of oncology at Fox Chase Cancer Center, and Michael Pearl, who's joining us, who's actually the lead palliative care person for the International Gynecological Cancer Society, but he's at Stony Brook in New York, and professor of gynecologic oncology. I will turn it over now to my colleague and friend, Sophia Michelson, head of the American Eurasian Cancer Alliance. Sophia, over to you.
Thank you, Stephen, so much. It's a true honor to be with you guys today. Steve and I worked together with our dear partner Alexander on the opening of the palliative care program in Ukraine for a very many months, and I'm excited that finally today, on July 11th, this day had arrived. American Eurasian Cancer Alliance had committed for cancer control and palliative care programs in Eurasia, and this is a second program in Ukraine that just started. We initiated the program with Ukrainian Gynecological Cancer Society that will be also taking place, interestingly enough, today, right after our conference. American Eurasian Cancer Alliance is committed to the well-being of Ukrainian patients, and I would like to introduce the person who is also dear friend and colleague, at the same time provides clinical oversight and associate director of Johns Hopkins Cancer Center. His name is Dr. Otis Brawley. He provides the clinical and research oversight of American Eurasian Cancer Alliance programs. Otis?
Thank you, Sophia. I want to first acknowledge our friends in Ukraine who are going through what no human being should ever have to go through, and doing it with incredible grace and dignity. And I want to welcome all of you to this meeting. Thank you for coming. I want to thank Sophia, who has been incredibly gracious in her own way as we have changed the National Cancer Institute funding for the project from Fox Chase to Johns Hopkins. I just want to reiterate that Johns Hopkins and myself are very much committed to supporting the American Eurasia Cancer Alliance and supporting this very, very important effort. For a very small amount of money, a lot of good is done, and I think that needs to be recognized. And I'm going to get out of the way so you can do your good work.
Thank you, Otis. Thank you so much. Stephen?
We can turn it over, I think, now to Alexander to introduce the case conference. And I must say, cervical cancer is really a major concern for palliative care globally. There are many efforts to try to improve care for women with cervical cancer, the highest rate of moderate to severe pain of any of the cancers. Alexander, please go ahead and introduce the person who will be presenting today.
Sorry, my microphone was off. And so, greetings to our colleagues from this first conference of clinical case presentation. And I would just like to express my deepest gratitude to our both American and British and other international colleagues for the support that they've provided for the development of palliative care and hospice support and care in Ukraine, because they were the ones to support the development of palliative care in Ukraine even before the full-scale invasion in 2022, and starting from that point onwards, also actively involved with for us and with us. This was a lot of material support, humanitarian support for the most complex and severe patients that we have. And so today, as we will see at this conference, this is going to be also the support in medical area, so medical practice and science as well. So yet again, thank you so much to our international colleagues, American especially colleagues, and for all the support to Stephen Connor, to our dear Sophia Michelson, and to our speakers as well. And I would just like to say a few small things. Today we have among us the representatives of administration and medical practice from health facilities that are providing palliative care, and also cancer care as well, from different and various regions of Ukraine. And I would just like to say that the presentation of today will be done by Olha Kirichko from Gadych Central District Hospital from Poltava region of Ukraine, which is northeast, just in case. And so the regimen is that we will be working today up until 5 o'clock Ukrainian time, so around 1 hour. And we will be discussing a case presentation. And if you have any questions, then please do place them into the chat. Any comments or questions that you have, please do leave it there. And the recording of the meeting we'll have. So if for some reason you're going to be disconnected or you can't be here till the end, we'll graciously provide the link to the recording of the meeting so that you can finish watching it at your time of your comfort. And so in that way, this is it that I wanted to mention. And I'd just like to pass the floor then to our dearest Olga. Olga, please, the floor is yours if you may. Greetings, can you hear me okay? Am I audible, visible? And I'm happy to welcome you from Ukraine and from Poltava region, from Gadych city, the city's and district central hospital. And right now the topic is palliative care in oncology. Therefore, I'd just like to pass the floor to our dearest head of the Department of Palliative Care, to Alexander Podorozhny. Greetings, colleagues. I'm so happy to be here. To your attention, I'd just like to present to you the palliative care case that we had in our department. It was a lady of 31 years of age. Am I not speaking too fast, or is everybody okay?
Говорите, у вас презентація
No, but if you want to share your presentation, can you also share it? Can you see that? No, you have not yet shared the screen. Can you kindly open it and then to do the share screen function, and so then you'll be able to do that. And just a sec, and select in your presentation. Where you have the microphone, just you can press the green one. Is the only one that's green. And just a second, we beg your pardon for that, because we do have the presentation on our screen, and so therefore we thought that you would be able to see it as well.
В самому Zoom там є кнопка.
So in the Zoom, as well as we did it,
Так, зараз завантажую.
and okay, now we sort of see that. Can you make it full screen if you can be so kind?
В правому нижньому кутку там є.
It's in the right corner, and so then, or you can press the slideshow on top of your screen, like anyhow.
У вас вона зараз на весь екран?
Do you see it in full screen?
Ні.
Unfortunately, we don't have that. Can you
Not yet.
В правому нижньому
press
кутку,
the
там,
skip
де
and
на
the right
сканування,
bottom
там
where you
можна
see the scales and percentages and all that? You can change it. There's like a book. Can you press the like book looking in the right bottom of your screen? Like see where you have 66%? Just to the left of that, there's like a, I don't know, like a post-it kind of button. Or if you could press it. So you mean here
No, no.
or
Біля
No.
машини віша, там є кнопка.
no, on the left
Режим читання називається.
here? It's just
Ось так. Тепер
okay. Now we can see that. Great.
Дякуємо вам велике.
Phil, thank you so much for guiding us through. Can we start? Right, good. So to your attention, we'd just like to present the following presentation. It was a female patient, and she was 163 centimeters tall. Her weight was 46 kilograms, and the body mass index was 18.4. She's not actively employed, so meaning she's in maternity leave, but she has an employment. She lives in the city of Gadech with her husband and 2 cities. They really have a good family, and they're sort of like an exemplary family. The main diagnosis that she had a malignant neoplasm of cervix covering a few adjacent areas. So it was the T2N1M0 clinical group 2. After she had the surgical intervention, radiation therapy, 6 courses of poly chemotherapy, and so she had a few complications. She had lymphostasis, or the stop of the movement of the lymph and the lower limb, right one specifically. She did have metastasis in the pelvic lymph nodes on the right and pelvic bones. She had severe anemia because of the tumor and hydronephrosis on the right. Then she had a stoma in the kidney and chronic lymphatic insufficiency. She was malnourished. She had a chronic pain syndrome. Malnutrition was to the 2nd degree, and she did have endogenous intoxication. She has secondary cardiomyopathy, chronic kidney disease, and you can see that the rate of filtration was 102 milliliters. So from patient history, she was declared sick from the August 2021 when she started to complain that she has like weakness, bloody discharge, and from last 2 months. And so 6 months ago, before that moment, she had her second child delivery, and it was conducted by the cesarean section. Then in October 2021, she had been examined by obstetrician gynecologist, and so during that examination, nothing of external sex organs has been differentiated, but this cervix had a sharp hypertrophy, so it was overgrowth and irregular in shape. It bleeds a lot whenever contact, and so there was a lot of discharge. So in general, in the blood count, the hemoglobin was 45 grams per liter, which is like really low. And then on the 3rd of November, she did a lot of oncoscreenings done of the chest, both of the abdomen and pelvis, and we did add the contrast. And so the signs of cervical tumor been present, and it was an unfortunate possibility of invasion of also her rectum. On this next day, or 4th of November 2021, during the biopsy conduct of biopsy material of the uterus, unfortunately, we found this squamous cell carcinoma with the presence of decay. On the 22nd of November 2021, by doing an MRI of pelvis and adjacent organs without any kind of contrasting, There has been signs of like a mass in this third top part of vagina, bilateral pelvis lymphadenopathy, so enlarged internal and external iliac lymph nodes there. And the patient was being treated in the regional oncological hospital. She got radiation therapy and polychemotherapy, started from the 11th, 22nd of November. Then she had in February of 2022 upon hysterectomy, and then after chemotherapy done, she unfortunately had the manifest of endogenic intoxication. She's been anemic, she's been really weak, like general weakness, and also she had symptoms of renal failure. Based on, and then by the decision of the Medical Social Commission, which is the one who declares you a person with disability, she decided she got the highest level of disability. By the decision of the groups of patients, she declared an palliative patient onwards from that moment in time. Then she'd been hospitalized into the palliative care unit. So our objective to hospitalize her was to correct and try to solve her intoxication and renal failure. We needed to select and adjust a good anesthesia and painkilling for her, and then mental health support. Initially, when she was admitted, if she was like a severe patient, on the pain scale, she had 8 points, and on a SOX scale, the general assessment was she got 3 points. The Karnofsky index was at 40%. The PPS scale for the general assessment of the patients was 40%. Then Barthel index on their daily activity was unfortunately only 40 points. So unfortunately, she progressively deteriorated of all of her bodily function. She wasn't able to dress up. She was not able to eat by herself. She has been really malnourished to the naked eye, and unfortunately, she cannot control the urination, meaning she could not go by command or when she wanted to do. So unfortunately, she complained, and also an even more general weakness. Then she had nausea, vomiting, shortness of breath, and also she felt pain and discomfort in the place or where the surgery scar is. And she has a lot of different pains, and so she gets medication. So rheocybilactosis is for the blood, like salts and everything else, the nobuphine, and then morphine, dexamethasone, metoclopramide, glucose 5%, aspartame, riboxine, dotaverine, and orlisson, analgin, dimenol, Spherifol. And also we did the blood transfusion, specifically erythrocyte mass. And so how she progressed. The patient had a urologic consultation based on the regional urology department. She had nephrostomy conducted, and after transfusion of those erythrocytes that we mentioned, the hemoglobin level from 70 increased to 106 grams a liter, and she had increased, and also the level of chronic pain decreased from 8 to 6, but unfortunately on the 3rd of August of 2023, based on her intoxication, she has died. And from our opinion, the questions for discussions are as of first, what are factors that led to her cervical cancer development, cervical cancer and pregnancy, and mental health problems when she was caring for cancer patients. And thank you so much for your attention.
Well, that was an excellent presentation. Thank you very much for sharing, in a very challenging case that your team looks like it did everything it could to well manage her condition. It seems that there were opportunities here for learning, and so I'd like to ask some of our colleagues to comment on the case presentation before we move on into questions from attendees. Tom, would you like to start?
I can. I'm Tom Smith. I'm a medical oncologist and palliative care doctor at Johns Hopkins University in Baltimore. Our daughter is a gynecologic oncologist, so she sees these patients all the time, but she's in clinic today and couldn't join us for the discussion. It's a very sad and tragic case because it's a young woman who's dying of a cancer that's very difficult to control once it's spread beyond the cervix itself. Our treatment here would have been essentially the same with a combination of chemotherapy, radiation, possibly surgery, and the complications would have been the same as well, because it's, you know, your cervix and your uterus are right in a very important part of your pelvis. So it's typical that it blocks the kidneys, blocks the ureter, blocks the urethra sometimes, invades into the intestines, and causes deep-seated, very difficult pain. The only thing I can think of that we might have done differently would have been to try pudendal blocks or hypogastric blocks to see if that reduced her pain somewhat. I'm not sure that it would have, and I don't do those blocks, so I'm not an expert in them. But everything else, you tried the best you could to control her pain, made her feel more comfortable with the blood transfusion, and hopefully supported her and her family as she died a very early death. But here she's left with children and a young father, as a widower. And I think they will need your continued support to get through the next couple of years at least. That's really about all I have to say. You tried everything possible to relieve her pain with multiple medications, and it succeeded some, but not very much. There's no way you could reverse her anorexia or her cachexia because of the severity of the illness. And so that wasn't even a possibility. So it's just a sad case. You know, most of these are caused by human papillomaviruses. There's specific types. They are preventable with HPV vaccines that would probably prevent 80 to 85% of these, but they have to be delivered early before someone starts sexual activity or soon after. The vaccines have also been shown to reduce most of the HPV-related oral cancers and anal cancers that we're seeing increasingly. So thank you for allowing me to comment.
Thank you, Tom, very much. Well, we do have a highly qualified gynecologic surgeon with us today, Michael Pearl. Dr. Michael Pearl, do you have comments or recommendations you can make?
Yeah, thanks, Steve and Tom. So I will start by maybe taking a step a little further back and follow up on Dr. Smith's comments about the etiology of the overwhelming majority of cervical cancers being HPV related. As we all know, trying to prevent is better than trying to treat. So with the advent of HPV vaccines, and then continued improvement in screening processes, the hope is that ultimately cervical cancer that's HPV related will be eradicated as a disease entity, and sometime in the future we won't be having these types of conversations. So I think that there were potentially some missed opportunities before this unfortunate woman came to y'all for palliative care. The first, I guess, potentially missed opportunity, and there's no history provided, you may not have the history, is on whether or not she was screened for cervical disease, HPV, or cervical dysplasia in the past. If so, then there's management that's available to try to prevent cervical cancer from developing, even in the presence of HPV and with dysplasia. So that's potentially one opportunity, and there, at least in the United States, there's plenty of data to suggest that overwhelmingly women who die of cervical cancer have had numerous opportunities to have been screened that have been missed. About half of those opportunities are related to the patient characteristics, meaning that she doesn't go for screening. And then half of those opportunities that were missed were on the physician care side. So there was some recent, not so recent now, but a very interesting study that came out looking at women with diagnosed cervical cancer. And it turns out in the 18 months before their diagnosis of cervical cancer, they had been seen on average 3 times by healthcare professionals who did not take the opportunity to perform a pap smear. So that's one issue, and that's true across all spectrums, but certainly in reproductive age women. The second is specifically in women who are pregnant. Generally, they should have an examination that includes a pap smear early in their pregnancy. It is very clear that unless, and even if this woman had HIV, she did not show up with stage 2 squamous cell cancer of the cervix 6 months following her cesarean section without having disease during her pregnancy. So there were some opportunities, I would suspect, during her pregnancy to have detected her disease earlier in the course. And then why is that important? Well, again, you know, if you're going to treat, the earlier you can treat in a disease course, especially in a cancer course, the better. There are some data that suggest that cervical cancer that develops during pregnancy has a worse outcome than cervical cancer that develops in the absence of a pregnancy. That has to do with changes in blood supply and blood flow with metastatic spread of the cancer. That's part of it, and obviously there's a reluctance to treat cervical cancer during pregnancy until the pregnancy is over. For those women who are diagnosed with an early cervical cancer during pregnancy, for those women diagnosed with early cervical cancer who are not pregnant, standard management, depending upon stage, is either surgery or radiation therapy with chemosensitization. Obviously, if they're pregnant and they wish to continue the pregnancy, surgery is not an option. So in those women, neoadjuvant chemotherapy has been proven to be successful and is reasonably efficacious and is also reasonably safe for the baby. Giving chemotherapy very early in pregnancy, in the first trimester, is generally an all or none phenomena. Most of the time, if they're going to go through, if they're going to have an adverse outcome in the first trimester, usually the pregnancy terminates on its own in response to chemotherapy. There is an increased risk of organogenesis failure or disruption with chemotherapy in the first 12 weeks. Once you get out of 12 weeks, past 12 weeks to the end of the pregnancy, generally there's not an issue with organogenesis, nor is there an issue with brain development, but the fetuses oftentimes are low birth weight. At birth, they have low birth weight, and so it takes a little bit longer for them to catch up, but catch up they do. So in a woman like this, if she was diagnosed with a cervical cancer during pregnancy and chose to maintain the pregnancy, our approach, and most of the people across the country, would treat her with a cisplatin-based chemotherapy regimen as a neoadjuvant regimen in the absence of surgery and radiation therapy. Once she delivered, and delivery by cesarean section is appropriate, if it was a very early stage cervical cancer that would otherwise be amenable to surgery, we would do a cesarean radical hysterectomy. So basically one stop for her surgery. If the cancer was larger and such that it could not be surgically managed, delivery by cesarean section, wait several weeks, and then start chemotherapy with radiation therapy with chemotherapy sensitization. So that would be the approach. Those were kind of the two areas where I could see there was potentially some missed opportunities before she presented to the palliative care service. With the palliative care treatment, I echo the comments of my colleagues. I think that she received outstanding care. So my background is I'm a gynecologic oncologist first and foremost. That was my initial training, and I still function as a broad spectrum gynecologic oncologist. About now 12 or 13 years ago, I went back to undergo formal training as a palliative care specialist because I was doing primary palliative care, even a little bit of secondary palliative care within my practice as a gynecologic oncologist. And palliative care for me has become the major focus of my academic career, mostly focused on gynecologic oncology. So I don't take care of men, I don't take care of children, I don't handle the non-malignant and mostly the non-gynecologic cancers. So I have a little bit of a different perspective than a palliative care specialist who is looking at patients of all types. So what do I mean by that? And maybe I have a different philosophical approach. When I'm trying to teach my residents, and we're talking about end of life issues or patients who come in for palliative care, meaning hospice type palliative care, not the full spectrum palliative care, but hospice type palliative care. I tell them that my job is to serve as a chess player. So what do I mean by that? Well, every move, and I'm a very poor chess player, but every move that one makes as a chess player needs to be calculated with regards to what's going to happen 1, 2, 5, 7 moves down the chess game if it's in a chessboard. But the same is true with medical care. So the most common cause of death for women with advanced stage cervical cancer is uremia. And I think that's what was meant by endogenous intoxication, is uremia, renal failure. And as Stefan said, as others have said, cervical cancer is probably if not the worst, amongst the worst of all the cancers to die from, because it is associated with the highest degree of pain and suffering of any of the cancers in men or women. So when we have patients come in, and we do have patients come in on a fairly regular basis who come in with uremia from bilateral ureteral obstruction, they'll come to the emergency room with previously undiagnosed with cervical cancer. They come in with uremia. And the problem is that the emergency room immediately calls the urologists, who then immediately do percutaneous nephrostomy tubes without us having an opportunity to sit down and talk to the patient about what her wishes might be and try to explain the anticipated course. So I tend not to push hard to do nephrostomy tubes or ureteral stents in women with very advanced cervical cancer where it's very clear that their disease is incurable. Yes, if they need a particular amount of time because they have to do something or make arrangements, so on and so forth, it's reasonable. But the difficulty is that it's always easier to do than to undo. And even though patients will say, well, I'll take my nephrostomy tubes out when it's time, that never happens. And so they end up passing away, they end up dying from something else. And during that time, they're suffering substantially. We're fortunate as some parts of the world that we live in an area where resource is not a limitation. We can do many things and have access to many different approaches. And so we can do the blocks that Dr. Smith described with our colleagues. It's not true in every place. And so I tend to try to counsel patients, look, I'm sorry, your cancer is going to kill you. And I'm one of those palliative care people where I'm blunt with my words. Your cancer is going to kill you. Here's what I expect to happen. Here are the possible pathways. And here's the pathway that I recommend. We will try everything we can to keep you comfortable, but here's one way that you can participate in your own care. So the final comment I have on this would be, because I've spoken a lot, is maybe the only thing that I would have presented to her slightly differently would have been when it was clear that she was in uremia and that she had ureteral obstruction. I would have had a very frank conversation about the pros and cons, the benefits and the risks, the upsides and downsides of trying to manage the uremia by bypass, whether it's a stent or whether it's a nephrostomy tube, or just leaving it alone and focusing on comfort measures, understanding that will, by not putting in a nephrostomy tube, we are not prolonging her life in an artificial manner. And I think I will be quiet at that point. So thank you very much for the opportunity to participate.
Thank you. Thank you very much, Michael, for your insights. And we're going to move on to Marcin, Dr. Marcin, but we do need to address, I think, some of the questions about opioid use and the psychosocial issues that have been referenced that are and how best to help the patient and the family in that process. But Marcin, over to you for a comment.
Hi, everyone. My name is Marcin Szwistek, and I'm a director of supportive oncology and palliative care at Fox Chase Cancer Center in Philadelphia. Very honored to be here with you all. This is a excellent presentation, and thank you everyone for comments. So I'll focus maybe on a little bit on what just Stephen mentioned, some of the principles about the opioid management and the psychological support. I think there were the questions that came from our colleagues in Ukraine. I think in my practice, I see patients both inpatients and outpatients, and oftentimes someone like her would be referred to as at the time of the diagnosis for ongoing symptom management and psychosocial support. I think this case was very challenging for multiple reasons, and I think age is primary. She's 31-year-old with very young family, so I think a lot of distress, I'm sure, from that reason alone. The cancer that was described, I'm sure was causing a lot of pain, and I think oftentimes what we see in those situations is a sort of a mix, somatic neuropathic pain that comes from the invasion of the organs in the pelvis, and there was mention of the invasion of the rectum. This is an area that's very rich in nerve endings, and oftentimes those patients will have a neuropathic component of their pain. So typically what we, and she also was mentioned, she also had infiltration of the lymph nodes with a lymphedema of the lower extremity, which I think was also probably contributing to her distress. Typically in those situations, we would start with an outpatient regimen of opioids, including long-acting opioids, to provide the baseline pain management for the patients, with the use of some as-needed short-acting opioids to address any exacerbations of her pain. And we would combine it with some neuropathic agents I'm not sure what you have access to, but gabapentin or tricyclic antidepressants would be something that we typically would add on to the opioid regimen and try to titrate it to find what I always call the sort of the happy medium, where you get the most pain relief with trying to minimize the side effects of opioids or other medications. So trying to come up with a regimen that would work the best for her. I think with the transition to the inpatient hospice unit, typically, and it seems like she was very sick at that time, we would transition her oral or transdermal regimens to intravenous regimens with most likely continuous infusion of opioids to address her dyspnea, to address her pain in the best way possible. We would sometimes also combine it with benzodiazepines to address the dyspnea aspect of it, although I recognize that she was in renal failure and probably some of this might not be necessary. One word of caution is that typically, with someone with renal failure, we would try to stay away from morphine. Morphine metabolites tend to accumulate and then can cause neurotoxic effect, like the myoclonus, or increase the confusion or delirium in those situations. So if possible, we would use either hydromorphone or fentanyl in place of morphine, if that's available. So I think that's probably how we would sort of approach it from the symptomatic point of view. I think that the psychological aspects of her case are tremendously important. I think, if, again, the young patient with a very young family and 2 young children, so not only for her, but for her family and caregivers, if normally we would refer those patients to either our psychiatry service or ask social workers to help. I think both the patient and her husband and children needed an ongoing support and discussions about her disease and what to expect in the future. And it's never easy in those patients, especially the young patients. But I think, preparing her for what's about to happen, knowing that her prognosis was very poor, in the best way possible, I think usually, in my experience, requires multiple discussions over time and to make sure that she understands what's happening in case there was anything that needed to be done before she died, any legal aspects or family-related issues, to letting her know that about the potential prognosis and time left to sort of discuss those things while supporting her, which always is tremendously challenging. And I think that's something that really needs to be a part of the sort of comprehensive care, in addition to all the medical things that we have been providing. So I think those are the major points that I wanted to make. I'm happy to answer any questions. But thank you again. It's wonderful presentations and certainly very challenging case on many levels.
Thank you very much, Marcin. Yeah, I think in the terms of the psychological issues there, it depends depending on her mental status. When you were seeing her, we use sometimes dignity therapy, helping sort of creating memory books, things like that for family members can be helpful in her feeling, and knowing how her family is going to do afterwards, making provisions for the future. And then, as Tom said, following probably for a longer period than the typical 1-year follow-up because of the tragic, circumstances around this and the pain. It's oftentimes traumatic to witness, the family to witness patients suffering that is at a higher level with cervical cancer. Would you like to respond to your case presentation and the comments you've heard? Would anyone like to comment or make or ask any questions at this point? Dr. Browley, are you with us still? Not sure if you had to leave, but if you have any comments, we'd welcome your thoughts. Looked like he was taken away. So, in response, Alexander, do you I'm not able to read the chat. If there are any questions that have come up in the chat, they're not translated. So could you help us with any questions that have been raised or comments? Alexander. Well, don't be shy. This was a very difficult case for our colleagues, and really we face some of the same challenges in the U.S., but in pretty much every part of the world. Cervical cancer is a huge concern, and we do have a partnership with the International Gynecological Cancer Society that Michael is involved with, Dr. Michael Pearl, and we're trying to integrate palliative care into gynecologic practice. But obviously we have patients who present with advanced disease and need palliative care support.
So I think the other issue, since nobody else is going to talk, I'm always free to talk. I think the other issue for us to remember is not just the patient and the family, but us. Women like this, patients like this, young, starting a family or in the midst of having a family, now leaving a very young family with a 6-month-old or 14-month-old, I guess, if I did the math right, but a very young child, leaving that young family with a partner is emotionally very challenging. And so independent of supporting the patient's partner and those that are around the patient, I think it's very important to remember that it's important to support us as well. Taking care of these patients is emotionally very challenging and demanding and stressful. And she's not a 90-year-old coming in having lived a full life who's going to pass away from age-related disease. This is somebody who died from a preventable disease at a very early age, leaving a very young family. And there's no doubt that has an impact on the caregivers, the medical caregivers, meaning us, you. So I think it's very important as you go through these processes to remember to take care of each other and to assess the impact of caring for patients like this on yourself, and have good coping mechanisms and appropriate ways to handle the emotional stress that arises from this. Because honestly, other than maybe a child, and I'm not even sure that taking care of a dying child is harder, taking care of these women is just about as difficult as it gets from a healthcare provider's perspective, from an emotional perspective. So we do it. Fortunately, it's not all that common, but this is my field. This is what I do on a regular basis, and it is really important to work with each other as a team.
So it looks like we do have a question in the chat regarding the type of psychological support provided to such patients. And I started mentioning that we oftentimes need, to help. And of course, every patient is different. And some patients have inner resources to cope with these situations, and some patients have limited resources psychologically to handle difficult reality. And this is a real very difficult reality. So we kind of need to understand where the person is in their coping with their life-limiting illness, and get a handle on what they feel they need from us, rather than assuming that they need that they can handle certain activities. But I've had a very similar patient to this many years ago, who was the same or about the same age and had 2 young children, and we worked with her for quite a while, and she decided that she wanted to actually make a kind of collection of her memories, kind of what her life was about, and those whole life, journals, if you will, sometimes can be helpful. Just dignity therapy, which is another approach to this problem. Dignity therapy that was developed by Dr. Harvey Chochnov in Canada is a structured sort of way of laying out your thoughts about your life and what you want others to take away from that, from you as well, in this case, as a parent. But there's also family meeting opportunities for family meetings. There's couples counseling that you could do just to work with her husband directly, because the children are very young and probably are, as Michael said, they're really small, really little children, so they're going to have a little bit of time participating in that kind of psychological support. So we try to help them come to grips with the situation together, to support each other, to help the husband separately to know what his stressors are, what his worries are, what his fears are, help him on a social level with how he's going to move on after her death. We don't have a detailed social history or psychological assessment. Are there spiritual concerns as well, should be factored into the assessment process? What kinds of support can he get from his social network, or people that, if he's involved in a church, what kind of support from the congregation? All those things are really important, because he'll have a difficult bereavement potentially, and what he can do to help his children understand what happened as they get older. There's just a lot of psychological dynamics to deal with in this sort of case. I hope that's a little bit of help. And we still have a few more minutes left. If we have other questions, we certainly welcome those.
Steve, I think there's a few in the chat.
Oh, here we go. What medications would be used in particular to reduce pain? Let me, Tom has, Marcin has actually commented on that. I think it was a useful comment to talk about use of morphine in these kinds of cases being oftentimes contraindicated. But Marcin, do you have anything further on that?
Yeah, just I think there's a question about specific. I guess it all depends on the availability of we would use any opioids. I think, as I mentioned, try to stay away from morphine, as knowing that she probably had the signs of renal failure pretty early. But we would use either oxycodone initially on long acting and immediate release to manage her pain, or you could use transdermal fentanyl patches or transdermal buprenorphine. That's probably what we would typically use in those kind of situations, and then combine it with whatever she could tolerate in terms of if there were signs of some neuropathic pain, either gabapentin, most likely given the fact that she was in renal failure, so that had to be also renally adjusted. Most of those meds do have to be. Something like this, we could also use methadone in more severe cases. We use methadone for pain quite a lot in our population of patients, and it actually can work really well in renal failure, and it works well for patients with neuropathic pain. Those patients with pelvic tumors actually tend to have quite a lot of pain, and oftentimes, even though we may start them on something else, then over time they get rotated to methadone. So that would be another opioid that we would often use. And then later on, as I mentioned, we would probably transition her to intravenous, patient-controlled analgesia to help her sort of figure out the best dose to manage the symptoms. And that could include either intravenous hydromorphone or fentanyl. I think those would be the sort of the main groups of meds that we would use.
Thank you very much, Marcin. Any other comments from colleagues?
I think, Stephen, there was a question about the role of social workers.
Oh,
And I think that also, if I may comment on this briefly, that depends on sort of in what capacity and how your social workers work. In our setting, our social workers actually function a lot as counselors. So they would meet with the patient and the family on a regular basis, to talk about coping, to talk about, their all personal social situations or circumstances, and try to find any ways to enhance their coping mechanisms and prepare them for what's going to happen, which obviously requires, it's a heavy emotional labor of guiding patients through this. But I think our role as palliative care physicians and oncologists is also to prepare patients for what is about to come. And I think that is incredibly difficult in a 31-year-old with a young family, but nevertheless, even more necessary. Oftentimes, I think also checking in with the patients to really find out their understanding of their illness. I think that, we didn't mention this, but, how much did she understand what was going on? Did she understand her prognosis? I think those are important things, and done in a way that is, maintains some hope, but at the same time, really anchors the family and the patient in the reality of what's happening. So I think in my experience, the sooner you start this type of work, the better. Knowing that this takes time and effort and the reiteration, and it's a sort of a dynamic process as patients and families react to it in different ways. So I think, again, once knowing, and having those discussions early it's always helpful.
Yeah, I think our experience with social work is it's often, if you get a good social worker that has clinical and counseling training, they can handle most of the difficult cases. But not all social workers have that degree of training. They do casework sometimes without that much clinical background. So a psychologist often is important to have access, particularly for difficult cases like this one, to provide more support. It looks like we're running out of time. We have a couple of minutes left. There's a question about equipment use, and we tend to be, high touch, low tech, and tend to not use as much hardware with patients as, though, I mean, adjustable hospital beds, of course, and the typical, commodes and assistive devices are commonly used. Hoyer lifts sometimes if we can't move, the patient's unable to move, but the equipment is not as big a factor to be concerned about. So let me just wrap up and allow Sophia or Alexander to make any comments about the experience today. We hope it was useful for you in terms of your clinical work. We do plan to continue quarterly conferences like this going into the future. We'd like to actually help the association educational system so that those particularly those working in palliative care, have access to not just basic, but a little bit more advanced training in palliative care. We care about your welfare and your work and these very stressful times, and want to send our every good wish to you. Alexander or Sophia, any comments, or Dr. Browley? Looks like we may have lost Sophia. Alexander, please.
Зараз дуже сильно подякувати.
I would just like to express my deepest gratitude. It was really interesting and in a good way interesting. So since I know that the time is strict to us, and the goddess of time or something is really strict, and she's pulling the hourglass, and but hopefully we will be continuing to move forward, and we will take into account also the opinion of like Ukrainian participants on what topics they're interested in, and like I will hear the feedback from everybody, so I will be happy to sum it up to you and what they think, because right now I'm not ready to answer, but I think this would be interesting, and thank you so much.
Thank you, Dr. Parvati,
To
for your
all of your
presentation.
time efforts,
and
for being here and for making an effort, because this is what matters the most. And we are also so grateful to all of you, dear colleagues, for such a wonderful online meetings. It was so nice to see you and meet you, and to have such a detailed and profound comments on this clinical case. Therefore, we will be more than happy to stay in touch, and we are so grateful to all of you. Thank you so much.
thank you, Michael Marson and Tom as well. We'll be seeing you again in a few months, we hope. So take care, do good work, and stay in touch.
До побачення.
See you and have a wonderful day. Thank you. Bye.
Технічну підтримку запитаю, там все в порядку, відбудеться запис, відбувався запис, і він буде.
Ми вам посилання надішлемо.
Два посилання там буде,
Так.
да? Мабуть, українське і...
Там буде 2 файла по одному посиланню. На файлообміннику буде.
Ага, ви саме файли пошлете, чи, мабуть, лінки, куди
Вам
ви
буде-
це завантажите?
Буде лінк на завантаження.
Ага, лінк на завантаження. Дуже дякую. Ми вклалися в годину, все нормально. Дякую,
Гарного дня. Так, до
пане,
побачення.
і велике спасибі перекладачу. Дуже вправно і дуже-дуже добре.
Все, гарного дня, до побачення.
Щасливо.